Good morning, good afternoon, and good evening, everybody. My name is Pierre Barker. I'm the Chief Scientific Officer at the Institute for Healthcare Improvement, and very happy to have you today joining us for this vital discussion on healthcare space design. As we know, the physical environment of healthcare facilities is more than just infrastructure. It's a powerful enabler of quality care, operational efficiency, and very importantly, for today's discussion, climate resilience. We'll explore these intersections with insights from leaders and experts in the field, and our speakers will take us through strategies and real-world examples for creating healthcare spaces that are not only functional, but also transformative for the people that they serve. We're very lucky today to have an amazing panel of speakers, exceptional experts and who are leading initiatives at the intersection of healthcare quality, sustainable design, and climate resilience. We're honored to welcome Blerta Maliki. She is the unit head for quality of care at the WHO, bringing her deep insights into integrating quality and resilience in health systems worldwide. We also have Minara Chowdhury. She's the Senior Director of Global Delivery at IHI and the project lead for Delivering More, which you'll hear a bit more about. Hema Maggie, she's the Senior Program Officer for the Gates Foundation, and both Hema and Minara are going to be talking to us today about how they've been involved in expanding access and improving maternal and newborn healthcare through innovative designs. We're pleased to have Amy Shao, Principal at Mass Design Group, who specializes in creating climate-resilient healthcare spaces. Always good to have an architect with us in these discussions. We also have Professor Mohammed Shahidullah, President of the Bangladesh College of Physicians and Surgeons, and he's a prominent neonatologist who's very involved in this conversation, along with Dr. Abbas Hassan, who's the lead executive officer for the innovation and quality at Ethiopia's Ministry of Health. Both Dr. Shahidullah and Dr. Hassan will be talking about some examples that I think will make this topic come alive for us. And last but not least, Anuradha Puchimani, who is a board member at ISQua, who will give us our closing remarks. So without much further ado, we can proceed, but I'd like to just make a couple of housekeeping announcements. I would love you to use the chat box. We will be collecting your questions, and there will be opportunities during the Q&A after the presentations. We have 2 opportunities for Q&A, and we'd just love to hear from you. So if you wouldn't mind introducing yourself very briefly in the chat box and asking your questions. And of course, we will be recording this presentation, and both the presentation recording and the slides will be shared after the meeting via email links to the website. So it's my great pleasure to kick us off with asking Blerta Maliki, who I think is at the WHO uniquely positioned to help us understand why designing healthcare spaces at this critical time when climate change is really so much on all of our minds. Can you tell us a little about the intersection between healthcare spaces and the changing climate, and how this is essential for the topic of quality of care, especially in low resource settings? Over to you, Blerta.
Thank you very much, Pierre, and good morning, good afternoon, and good evening to all participants who have joined us. As Pierre said, climate change facilities, healthcare systems, and healthcare outcomes with quality at the center are all intertwined. And we are now living in a world that is very diverse and changing at speed that we haven't seen before. Hence, we need to take care more than before in relation to the facilities, how they're designed, what they mean, and what is their impact in climate change, but also how climate change is impacting the design of facilities by keeping in mind outcomes. Next slide, please. So the climate crisis threatens to undo the last 50 years of progress in development, global health and poverty reduction, and to further widen existing health inequalities between and within population. Research shows that 3.6 billion people already live in areas highly susceptible to climate change. Between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from undernutrition, malaria, diarrhea, and heat stress alone. Furthermore, climate change is undermining many of the social determinants for good health, such as equality, the access to health care, and social support structures. These climate-sensitive health risks are disproportionately felt by the most vulnerable and disadvantaged, including women, children, ethnic minorities, poor communities, migrants, older populations, and those with underlying health conditions. The direct damage costs to health, and this is excluding costs to health-determining sectors such as agriculture, water, and sanitation, is estimated to be between $2 to $4 billion per year by 2030. Next slide, please. Climate change is impacting health in a myriad of ways, including by leading to death and illness from increasingly frequent extreme weather events, such as heat waves, storms, and floods. Some of the most recent that we witnessed were in Spain, not longer than 10 days ago. The disruption of food systems, increases in food, water, and vector-borne diseases, and of course, mental health issues. Climate change impacts health both directly and indirectly, and is strongly mediated by environmental, social, and public health determinants. The figure that you can see now provides an overview of climate-sensitive health risks, their exposure pathways, and vulnerability factors. Climate change is also having an impact on our health systems, workforce, and infrastructure, which is the topic of discussion today, by reducing capacity to provide what we are all aiming to achieve, universal health coverage. Areas with weak health infrastructure, mostly in developing or low and middle income countries, will be the least able to cope without assistance to prepare and respond. In this context, WHO and partners over the last decade have intensified their work in trying to understand, think, conceptualize, and then move into action on how to respond to the risks of climate change, but also how to reduce our impact that is leading towards the climate change. Among the myriad of documents, there are three key frameworks that help us to understand and address climate change and their impact in the healthcare facilities. And I'd like to draw your attention in all of them, but we will focus in only one of them today. First is the WHO strategy on health, environment, and climate change, and is a framework for building climate resilient and environmentally sustainable healthcare infrastructure and facilities. And finally is a strategic framework for WASH, climate resilient development. All the frameworks are intertwined. They all call for actions that are in relation to promoting reduction of carbon emissions and improve health, build better, more climate resilient and environmentally sustainable health systems, and protect health from the wide range of impacts of climate change. As you may see by going through those documents, but also from a conceptualization perspective, healthcare facilities are at the center of our response in order for us to achieve health, to have a healthy people and also a healthy environment. And it is a combination between all the factors, infrastructure, technology, water, sanitation, workforce, and energy that can allow us to think through critically on how do we build the climate resilience of our health systems and facilities, but also how to respond and ensure environmental sustainability. Next slide, please. So allow me to take a closer look at the framework for building climate resilient and environmentally sustainable healthcare facilities. The framework aims to enhance the capacity of healthcare facilities to protect and improve the health of their target communities in an unstable and changing climate, and to empower health facilities to be environmentally sustainable by optimizing the use of resources and minimizing the release of waste into the environment. The goals are to provide countries with guidance aiming to increase the climate resilience, protect and improve the health of their communities in an unstable and changing climate, optimizing the use of resources, And finally, minimizing the release of waste in the environment and becoming environmentally sustainable. The conceptual framework that sits in the document illustrates the dynamics affecting the climate resilience and the healthcare facilities. So our health facility faces a shock or stress. In relation to climate change, this could be an extreme weather event, such as a cyclone or a flood, or slow onset climate changes, such as temperature increases. The capacity of the healthcare facility to deal with this shock or stress is determined by its level of resilience. What is the exposure of not only the facility itself, but aspects of the facility that keeps it functioning. For example, healthcare workers, medicine supply chains, and in this I would include facility and the facility design itself. This vulnerability will impact the choices and opportunities available to manage shock or stress and ultimately the outcome of the facility. Ideally, we want the facility to recover better than before after the shock, even to transform. But if the resilience is low, it is possible that it may never recover, or worse, it can be worse than before or even collapse. So to increase the resilience, we can decrease the vulnerability and increase the capacity. And this is what I would like to underline. The facility infrastructure and the facility design are very important capacities and impact the facility resilience, and by default impact the healthcare that is being provided and the quality of that care. In the healthcare facilities, we would like to ensure that each of the fundamental input-driven requirements for providing safe and quality of care are climate resilient and environmentally sustainable. As such, healthcare facilities should be able to anticipate, respond, cope, recover from, and adapt to climate-related shocks. We would like them to be able to minimize negative impacts on the environment and restore and improve the environment. And as you see, among those 4 conditions and 4 fundamental requirements, design, facility, and infrastructure is a very important part of that. So there are a myriad, at the end, we need to navigate the environment. There are a myriad of interventions that we can implement to ensure healthcare facilities are resilient and environmentally sustainable. At the same time, there is no prescribed process for implementing interventions, as those interventions, they need to be context specific and respond to the needs and the context in which they are operating. However, there are a number of tools that can support this decision, and that starts with the very first one, which is establishing the baselines to inform decision-making and identification of interventions, such as checklists, greenhouse gas assessment tools, etc. Use the baseline information to define and prioritize the most appropriate interventions, develop the plan and implement it, and finally monitor and evaluate. So in a way, even the climate response has adopted a PDSA and quality improvement cycle on how do we respond and how we ensure that facilities are resilient. With this, I would like to close and hand over to Pierre by saying only one thing. The entire discussion today is going to be around facility design and how that affects the quality and the impact in the health of women and children. This is a very good example on what we need to think for the future, not only in relation to maternal or newborn wards, but how do we have to think of the redesigning of facilities across all levels of the health system for them to be resilient, but also to be able to continue to provide quality care to everybody all the time, despite the conditions and whatever changes we may face in the future. Pierre, over to you.
Thank you so much, Bleta, and what a great introduction to the topic. And I think it's pretty clear from your presentation how important the actual facility itself is going to be increasingly important as we move forward, and particularly with what's coming at us with climate change. And I think it was a really good illustration about how the facilities, certainly in the case of climate change, are both contributing to the problem through waste and carbon emissions, but also how much the community really depends on the facility at times of crisis and stress. And I love the way you described the stresses as being either sort of slow and long term, which I think applies to the rest of the conversation that we're going to have, or acute stress, where the community really does rely on a a facility's resilience to be able to not only withstand the stress, to be able to provide care in the moment, but also as a place of refuge. So I think this is a really good segue to the next part of our conversation, which now moves to a more everyday kind of clinical topic, really about the key influence that the facility can have on the experience of care from the patients who are coming in. And this is where I'm going to turn to Minara and Hema, Minara Chowdhury and Hema Maggie, who have a lot of experience, certainly in thinking and trying out some of this thinking around how the facility design can help us. So starting with Minara, what is the underlying philosophy and approach to how we can use facility design to make the pursuit of quality happen better, and what have you been doing to advance that idea?
Thank you so much, Pierre, for that. And good afternoon, good morning, good evening, everybody. So I'm just going to take you through some slides, but really have introduced this notion of the case for space. Why do we need to worry about space? And thinking very much about the presentation that from Berta in the light of climate change, how do we build that case for space? So quality, if we want to deliver quality of care, we require spaces that really meet the needs of the care that we're going to deliver. So firstly, the design of the facilities really help influence whether families seek care. And that really is the demand question as we look at facility-based care. It's one of the determinants of why somebody would want to go to a facility to deliver. They look at how the facility is designed, what are the adjacencies of the various departments, how much do they have to move around. So really, it influences their demand. The layout of the services also influences access. And by access, I mean how the patient, their families come to the facility to seek care from the clinical staff at a time when they really need to and they're most in need of care. And finally, the design of spaces also influences patient outcomes and experience. And that's the quality dimension. Because if somebody is more comfortable in staying in a facility, they're more likely to stay there for longer and therefore access those services. However, the challenge that we have, that space is often overlooked. And this particular image, it is not something that's very different to what we've seen globally in many different countries. And really, space becomes as a background, as an enabler, rather than a central driver of quality improvement. And the scene of overcrowding or inadequate spaces for people waiting is one that's very familiar. And poorly designed buildings keep on getting built. But we do have an opportunity to change this. So how do we make that change? And what are those drivers behind making this change? Because as it happens, buildings keep on getting constructed and we keep on using the existing layouts and existing agencies, and often without communication between the care seekers, the caregivers, and the architects, and that leads to poorly designed buildings. So in terms of how do we now move ahead? How do we think about space, and what are those enabling kind of elements and components that we need to think about? Well, first and foremost, we need to think about evidence-based care. And some of these, I'm going to quickly, I mean, these are images, but one of those areas are kangaroo mother care, and how do we provide that service? How does the mother provide the service? How do we let those mothers stay in that facility for longer? How do they feel more comfortable? Mother NICUs is another one, mother newborn intensive care units or neonatal intensive care units. Again, for extended periods of stay, we ask mothers and newborns to stay in the hospital. How do we design those spaces? And then again, in having mobility during labor and those position of choices, having a walking area, using different aids, how do we enable that to happen? This point, Hema, I'd love to ask you, what are your reflections from what you've seen in your time doing this work?
Yeah, thanks, Manara. You know, this is one of those things that as a practitioner, you know, when I've spent about 10 years living and working in rural Rwanda and then in Ethiopia, really trying to provide high quality care. In particular, when I think back on time in Rwanda, I found this to be really salient. I remember we were, as you're looking at evidence-based care and science and care has evolved. Suddenly we have, not suddenly, but we started to really try to think about things like birth accompaniment, how to support women through labor. And then kangaroo mother care, something that I think very many people in the global community tried to say was a simple, cheap, and affordable way of dramatically improving outcomes for preterm and low birth weight babies. Yet everywhere I looked, I'd see women or babies bundled in beds and women outside. And when you think about why this might be, then I would go into facilities and you realize it's the same cookie cutter design that feels like it was from the 1950s everywhere. And so that has not seemed to evolve in any way as the content of care and the evidence and the interventions has. So I feel like it's no wonder that it can be a challenge to implement high quality care. So if you take, for example, kangaroo mother care, I thought was such a great example. In you know, in multiple countries I've seen this, but I just reflecting back in particular on examples in Rwanda, finding that you were looking at kangaroo mother care and there was a tiny room with no windows and maybe 2 beds and a sign above it saying kangaroo mother care. And then you'd wonder why it's empty. And meanwhile, because it felt like, who would want to be there? I was like, I wouldn't want to be there. I wouldn't want my baby to be there. And I'm not getting food. I'm not getting any care. No one can actually monitor my baby. Why should I be there? Then at the same time, you know, I saw how this evolved really firsthand. In this particular example, we actually had the opportunity together with partners at Mass Design to redesign our neonatal unit. And it turned into a large, big room. And it was a very simple design, just a room. And we didn't have the equipoise at the time for immediate KMC. So we still had a little incubator room. But then we just had one big room. And in that space, suddenly we started to see kangaroo mother care happen. Women were together, moms and babies were able to, moms were able to see babies make that progression from the sicker time in incubators to then being able to graduate into kangaroo mother care. And I think we started to see things I never would have even predicted. It was the women themselves who became the greatest champions for kangaroo mother care. So in that way, I felt like these were things that you may not necessarily think of until you're physically in the space. I think the other important thing is that while, you know, is the perspective of healthcare workers. Suddenly, with this nice big space with windows and light, you had one central nursing station, and nurses could actually see all the babies instead of them all being in tiny little rooms with lots of walls. And frankly speaking, usually based on incredibly outdated thinking around infection prevention and control. And so science has evolved far beyond where I think some of the physical layout and structures have.
Thank you so much, Hema. That's really such a powerful image that you provide. I love the way you spoke about cookie cutter 1950s type designs, because I think sometimes, or we are absolutely sort of following patterns of designs that we can actually change. And I think that's the exciting look ahead that we have of today's session. That very powerful image of mother in a very stuffy room versus your next image of an open space that benefits not just mothers and their babies, but the healthcare workers themselves is really exciting. And that's a great segue to a question that I now have for Amy, who is really leading the conversation, certainly for us, and really the conversation about exciting alternative designs that could make us hopeful, I think, about the future, both with regards to the climate issue, but also this very pressing issue of the immediate space that patients and healthcare workers find themselves in, and the extraordinary influence that it can have on quality. So I wanted to ask Amy briefly, just to tell us a little bit about the conceptual pillars behind the architectural designs that are now being proposed to address these issues. And so over to you, Amy.
Great, thank you. So MAS was founded on the premise that design is never neutral. It either heals or it hurts. And as Minar and Hema spoke about, our physical spaces, the design of our health infrastructure can really affect how individuals and communities heal, but it can also affect our ability to flourish at a much bigger scale. It's really clear to all of us that our health is inextricably linked to the health of our planet. And on the next slide, there are a lot of components, as Loretta highlighted, to build climate resilient health systems, but infrastructure is one of the most overlooked and under-leveraged. So yes, it's absolutely essential to ensure functional and sustainable water, waste, and energy systems, and to reduce the vulnerability of infrastructure to disasters. These are photos from a facility that endured a lot of flooding and was destroyed. But climate resilience really requires thinking bigger and shifting from a mindset of mitigation to one of restoration. The next slide. I just want to quickly reflect on 4 ways that a climate resilience lens can help us think about how healthcare spaces can be more adaptive and resilient from the outset. So the first is reducing our contribution to climate change and doing less harm. The building and construction sector accounts for almost 40% of global carbon emissions and uses half of our natural resources. So beyond adding sustainable interventions like solar panels to buildings that are poorly functioning, what if buildings were better designed for their climate context in the first place, lowering energy consumption and disease transmission as well? So this image of the Butaro District Hospital, which we designed in Rwanda, harnessed its hilltop location and temperate climate to create a campus of smaller buildings with natural cross ventilation and exterior hallways to actively reduce crowding and airborne infection. And for the New Redemption Hospital Caldwell in Monrovia, Liberia, we leveraged large solar chimneys to pull air up and out of a multi-story building using very simple natural stack ventilation principles. Beyond focusing on just the operation piece of buildings, what if we also paid equal attention to how buildings are built, to the embodied carbon of what goes into our buildings in the first place? More environmentally and ethically sourced building materials could not only lower our carbon consumption, but create healthier, non-toxic indoor environments and also offer job creation and economic opportunities to local communities, which makes them more resilient to shocks. By using local materials like stone, earth, wood, clay in one of our projects in Rwanda, we were able to reduce the upfront embodied carbon of construction by 60% compared to typical building methods. And then beyond more thoughtfully selecting sites and building structures that don't fall down, we could do better. Imagine a world where infrastructure is really proactively poised to respond to climate disasters and pandemics. For the Samagic Hospital in Bangladesh, designed for the Grameen Foundation and Muhammad Yunus, we intentionally designed the entire site landscape to accommodate urban flooding so that the circulation paths and the critical paths remain accessible. It also has a combination of natural and mechanical systems to ensure airflow even in case of power outages, as well as open air porches between wards to offset crowding. We also really paid a lot of attention to designing the overall master plan to accommodate future pandemics. So by connecting the hospital and the medical school into a larger mega block the hospital will be able to kind of flex and expand to provide additional services in pandemics and other emergencies. And then beyond ensuring that we have robust health infrastructure for treatment of disease, imagine a world where regional health systems have the full network of surveillance and diagnostic infrastructure to stop pandemics in their tracks. And this was the aim of ISQua in Nigeria and Biomed in Rwanda. Beyond conserving resources and minimizing disruption, which were what we talked about so far, what if we could foster health by balancing and restoring ecosystems? Buildings will never be climate positive on their own. We need really regenerative landscapes that restore ecosystems, increase biodiversity, sequester carbon, and foster One Health, which refers to an integrated approach about balancing the health of people, animals, and the environment. And this is something that can be done in facility health master planning, even and especially in limited resource settings by considering sites as part of larger ecological systems. So the site selected for the Redemption Hospital in Monrovia was a really stagnant, overgrown wetland that was fostering mosquito breeding. And rather than look at that as a problem to be filled in and drained, we recognize that restoring a healthy wetland would have positive outcomes for not only patients, but the surrounding community. So we designed water infiltration swales to improve water quality, forested the wetland edges to attract predator birds and regulate erosion, and then deeper pools to increase circulation and reduce the mosquito habit. Another really important element of resilience is adaptability over time. As I think Lorta mentioned, it's important to design for short-term adaptability in times of crisis to allow health infrastructure to flex or adjust. This was a cholera treatment facility we designed in Port-au-Prince that was originally intended for diarrheal disease. So we optimized cleanability and ventilation in the design. But when COVID hit, it was able to pivot to serving COVID patients. And then it's also important to design for long-term adaptability. So how do we allow buildings to grow and evolve along changing models of care, to Hema's point? The Redemption Hospital in Liberia, for example, is a phased project. 150 beds are being built in the first phase, but the master plan anticipates the addition of other buildings over time, as did this smaller scale maternal health clinic in Zimbabwe. So this is the image of the ward that Hema was talking about. It's simple, it's not extravagant, and so I think it's just important to conclude with the idea that good spaces, climate resilient spaces, don't have to be fancy or extravagant. They just have to be really thoughtful. We often get asked what the cost is of doing things right, but we need to look at the bigger picture. Next slide. Time and time again, we've seen a lot of waste happen within healthcare systems when we take the short view. When things are built cheaply and don't meet needs, that's really wasteful in the long term. One facility we're working on in Kenya, we saw a recently completed OR. This is not the picture of that. That was built with ceilings so low and weak that it couldn't support the surgical light and never opened its doors. And what is less sustainable than buildings that sit unused? So to create really meaningful and transformative change, we all must champion longer term thinking and investment in the built environment and expand our mindset around what a world of climate resilience could be. Thank you.
Thanks so much, Amy. I think we'd like to switch now to some deep experiences from the field. Both Prof. Shahidullah and Dr. Abbas from Bangladesh and Ethiopia, respectively, have been working at the interface of the clinical care and the space when it comes to maternal and newborn care. So I'd love to invite first Dr. Shahidullah to share his experiences from Bangladesh and tell us a little bit about the research that he's been doing. Dr. Shahidullah.
Thank you, Pierre. First of all, I'd like to thank particularly Blata to set the ground about the magnitude of problem of climate change and its impact with the healthcare facility difficulties by Minara and Hema, and also Amy has shown us the importance of changing the design in terms of during the time of need. So with that note, actually, I will share with you about the human-centered design for maternal and newborn health. And when I'm saying this, actually, I want to emphasize on IKMC, which means that it is immediate kangaroo mother care. And when I say it's immediate kangaroo mother care, means that so far our common understanding that if a baby is sick, the machine should take care of the baby. Now, we are telling that it is the mother should be empowered to take the care of the baby. So machine to mother. Just few figures, we all know about it, that every year 20 million infants are born with low birth weight, and more than 95% are in the low and middle income countries. And that's not the end of the story. It accounts about 70 to 80% of all neonatal deaths. Now, that's about the death, but what's their actual long-term consequences? These low birth weight infants are at increased risk of early growth retardation and as well as the developmental delay. Now, first of all, I'll share with you about the kangaroo mother care, then immediate kangaroo mother care. Kangaroo mother care is a very effective intervention that can actually reduce the mortality of preterm and low birth weights. And it is about 32% in the neonatal period. And just think about that, it can also reduce 25% by within the first 6 months. And when I'm saying this, but at the same time, I like to remind everyone that longer the kangaroo mother care gives a better benefit. So at least we need to give kangaroo mother care more than 8 hours. Now, when this is so important intervention, when should we begin? And that's the question, when should we begin? Means soon after birth, and that is known as early initiation of kangaroo mother care. And it has shown that 23% of neonatal deaths were reduced by introducing early initiation of kangaroo mother care. And there is a probable decrease of about 15% of clinical sepsis, which we are struggling in the conventional scan, that the baby is given care for thermal care, nutritional care, but they are getting sepsis. But in the kangaroo mother care, the sepsis is reduced by about 15%. Next slide, please. WHO has made a big kind of a recommendation in November 22 through its guideline development group, and I was fortunate to be a part of that. And they made 4 big changes in the recommendation. The one recommendation was that in the past, we recommend that the babies born below 2,000 grams should get KMC. But it is now said that any baby born below 2,500 grams should get KMC. The second is that KMC initially was thought to be introduced when the baby is clinically stable. Now it is said, no, don't wait for that. If the baby is still clinically unstable, you can put the baby on KMC. Another one is that everyone thought that KMC can only be given in the facility setting, but KMC can be introduced and also can be carried out in home. And the 4 big difference that we made, that at least 8 hours and more KMC should be introduced. If it is longer than 20 hours, maybe 24 hours, the best. So what is immediate kangaroo mother care? It tells about the baby should be put on KMC immediately after birth. That means a baby mother has delivered the baby, either by vaginal delivery or by cesarean section, put the baby to the mother's chest. 0 separation. And then if the mother can be transported with the baby, fine. If it is not, somebody else as a surrogate will carry the baby to the KMC ward. So while I'm talking about immediate kangaroo mother care, that's now about the things that we have to consider. And my predecessors have already talked about the infrastructure. So we need to actually have an infrastructure where not only the baby, but the mother can be kept together in a very comfortable way. And for that, you need to have an enabling policy, and where we can offer the care to the sick baby, and at the same time, we can provide the care to the mother. And when I'm saying this, actually, we need to strengthen our small and sick newborn care. And that small and sick newborn care is not a rocket science. It's already there. Can you actually put the pressure so that I can see Next part of the slide. Yes, and it is not a yes, it is not a standalone intervention. Actually, it is nested in the routine care for the small and sick newborns. So it's something that we are bringing a standalone program. Now I'll be sharing with you some of the experience. To initiate kangaroo mother care in the delivery room, now we need to have a newborn care corner in the labor room and OT, which in most of the situation in low and middle income countries was not there. And we all know that the mother has delivered. We put the baby to the mother. Now the baby should be transported to the KMC ward. Who should carry? Mother is already having operation, and cesarean section will be in the post-operative ward. Somebody, either father or anybody, grandmother, somebody surrogate should be waiting outside that delivery area. So here is the picture of that. And the experience from Tanzania, India, and Nigeria, where the surrogate can carry the baby, having skin-to-skin contact from the delivery room to the KMC ward. And for that, the support person and surrogate starts the KMC in the KMC ward because mother is not available there. When mother comes in, so mother takes over. And here are the pictures of in our country. The first ever this mother's canoe was developed in MR Kanshi Hospital back in 20th of May. It's not even 6 months. And after that, followed by some other establishment of mother baby. So my point here that this canoe, which is a conventional one, where the sick babies are admitted, mothers and the parents are waiting outside anxiously. Now, mother and baby should be in the same place. And for this, we need to have a mother's bed and with all supports for the baby. That very strong, important thing is that mother should not be considered as a visitor. Mother should be considered as a provider. Next, please. Yes, that's the thing that infrastructure, I'm not going detail that how there should be mother's bed, there should be mother's toilet, mother's shower facility, a pantry to have some foods, and a counseling room. So what are the opportunities provided by Mother's Canoe? Is that it improves opportunities for kangaroo mother care. It actually helps in zero separation. It gives the opportunity for mother to be the primary caregiver, not the nurse and the doctor. Infant and family-centered care can be initiated here. Mothers better prepared for post-discharge care of the baby. Mothers get more support for breastfeeding, less anxiety and stress, better parental satisfaction compared to the NICU, where the mothers are anxiously waiting outside the NICU, and improves opportunities for counseling the mother and discharge preparedness. So when I am saying that IKMC implementation, there are, of course, issues and concerns. And those are very, sometimes very serious, actually, like infrastructure, labor room and SCANU are in different floor in the same hospital. Sometimes the labor room and OT and the SCANU are in different building, creating more challenge. So we need to have an enabling environment in the mother SCANU where mother-baby dyad remains together with all the facilities and needs of the mother and care provider, bed, bath, food, and toilets. The other issues and concerns are actually policy supportive of IKMC, where mothers given right and means to stay with the babies and all those things that I've said. But one thing is that the other challenge is that the mother's care must be provided by the OBG people coming to the mother's scanning. That's another issue and challenge. And WHO coordinating, and when we said that this KMC is found to be very effective, but that's in the controlled, environment through the research. But we need to actually, if we go for scaling it up, then we need to have a implementation research. And WHO is actually doing that. So that why immediate KMC scale up implementation research is one that experiences limited to the trial environment. Evidence gap is in how to deliver IKMC and scale up the model, identify effectiveness of the model in real life program settings that we are learning now. And in Bangladesh, these are the countries where this IR is going on. In Bangladesh, we have got 2 places and we are having a lot of challenges, facing a lot of challenges. We are trying to fix it and we are learning it, but we are very sure that eventually at some point of time, we will be able to have a very nice mother SCANUs across the country, and therefore a better newborn survival and mother's care in one place. I think that's the last one, and that's the photograph that we people who are working for that were together. Thank you.
Thank you so much, Dr. Shahidullah. What a great description of all the activities that are happening in the space. And I love the idea that you just described of how much is being learned from all of these country sites. I'm sure this is a story that we're going to hear a lot about in the coming months and years. So now if I could switch to Dr. Abbas, who works with the Ethiopian Ministry of Health, and I think can perhaps give us a perspective on some of the questions that are coming through about the realities of trying to design better spaces from the perspective of the ministry. So Dr. Abbas, please do go ahead.
Thank you, Pierre, for your introduction. So next slide. So my presentation will have these 5 parts. For the sake of time, I will focus on the fifth one. Next, please. So as we know, human-centered design focus on creating spaces and systems that prioritize the needs, preferences, and experience of users. In the context of maternal and newborn health, it can significantly improve outcomes and meet the needs of mothers and their newborns by addressing their physical, emotional, and social needs. So this is the Ethiopian health tier system. We have 3 health tier system. You have the primary hospital, secondary, tertiary, and we have around more than 370 hospitals, more than 3,800 centers, and more than 18,000 health posts, which are well functioning. So design and space is a priority agenda in our national policies and strategies, especially in our health policy. It is the main agenda, and it is also a key intervention or priority area for the sector development and investment plan in Ethiopia. It is also part of the National Specialty and Subspecialty Service Roadmap and Health Extension Program optimization roadmap as well. So the National Healthcare Quality and Safety Strategy also focus on availing better design and space for providing high quality and safer health services. It is also among the 4 priorities in our regulatory standard. As you know, most of the regulatory standards have 4 priority areas: the premises, the product, the professional, and practice. So premises is the lowest scoring area among the others. So it is very important to focus and to emphasize improving design and space in all our reforms. So in Ethiopia, we have structures and coordination platforms to have a better infrastructure and space. Infrastructure and design is a national priority agenda for the National Health Innovation and Quality Steering Committee, which is mainly composed of donors and other government agencies. Health Infrastructure Directorate and Biomedical team is established here in Ethiopia. In most of the countries, infrastructure and design is led by Ministry of Construction and urban development and other sectors. In our case, we are very unfortunate, and it is led by our own ministry. So we have different structures at regional, as well as facility level. We are also working on the developing a better to have a better health infrastructure workforce, especially we are working to have a masters of health infrastructure, especially training. It is on dialogue. For sure, we will start the program very soon. In addition to that, we are also working on raising funds from different sources, from the government, from implementing partners, as well as investors. So design and space planning is integrated into major healthcare reforms. The major considerations are human-centered design for maternal and newborn health, climate resilience, space as catalyst for better quality of care, as well as influence of space on design and on enhancing health-seeking behaviors. So I have 3 showcases on human-centered design for maternal and newborn health. The first showcase is immediate kangaroo mother care, which was almost done by Dr. Shahidullah. Please next. As you see from the picture, we have already national guideline for immediate kangaroo mother's care. Based on this guideline, we are providing the service. So in Ethiopia, the kangaroo mother's service was introduced in 1960 at Tukurambasa Specialist Hospital in Ethiopia. Then has expanded to other special hospitals and health facilities. And the major design consideration is upgrading and renovating health infrastructure and design to create designated areas and conducive environment for KMC within maternity wards that allow for privacy, comfort during the KMC. Next, please. So the proportion of preterm newborns who received kangaroo mothers care increased from 60% in 2022 to 67% in 2023, and we are also planned to achieve 70% in 2025. Please next. The other area is newborns intensive care unit. Please next. So Ethiopia has recently invested nearly 24.5 million USD for 80 hospitals, one in each zone of the country, to establish, upgrade, improve the newborn intensive care unit, NICU, to level 3 to avert the neonatal mortality rate. The main design consideration is placement of maternal neonatal and care unit to adjacent to delivery rooms to facilitate immediate postnatal care. So through this intervention, the proportion of newborns admitted to neonatal intensive care unit who recovered increased from 60% in 2022 to 80% in 2023. The other one is the last one is the maternity waiting home in Ethiopia. Maternity waiting homes are residential facilities near to health facilities that provide a place for pregnant women to stay during the final weeks of the pregnancy. It is aimed at to improve access to the obstetric care for pregnant women in rural areas, and it provides recreational service to create unforgettable memories for mothers, especially coffee and porridge preparations are the part of the service. So the program is in reduced pre and postpartum maternal and newborn morbidity and mortality. for the sake of time, I would like to stop here. Thanks so much.
Thank you so much, Dr. Abbas. I really appreciate that comprehensive view. And I think it's so important to understand, and it's going to come up, I think, in some of the questions that we're seeing coming through about how do we get some of these emerging ideas into national quality strategies. And I think Ethiopia's example really is a terrific way of understanding really the seriousness with which your government is taking this question and building it into national policies. Before we go into the panel discussion, I wanted to ask Amy to briefly discuss how do we take some of this research and package it into what we call the global goods, so that these ideas can become much more accessible to providers and governments around the world. So Amy, can we hear from you briefly about the introduction of the global goods to the conversation?
Yeah, thank you, Pierre. So as Dr. Shabdul and Dr. Abbas just shared, we know about interventions that improve outcomes and save lives. Next slide. But when we don't have the right spaces, we can't implement these care practices. Next slide. So our work on delivering more has been really aimed at putting space, the physical environment of health facilities on the global agenda for maternal newborn health. Next slide. We've been working together over the last couple of years to engage stakeholders, patients, family members, providers, health system leaders in Ethiopia and Bangladesh to understand what model MNH care could look like, assess existing facilities, and recommend a series of improved facility designs. And then in parallel, we also distilled our process and learnings into a human-centered design toolkit for improving maternal newborn care spaces. Next slide. So just quickly blast through some of the documents in here. And it's all downloadable online. We can put the link in the chat. So there's an executive summary, which really just documents our process and reaffirms the importance of space in health outcomes. There's also a film piece as well. Next slide. The facility design guide lays out a process roadmap for designing improved spaces. Next slide. It has two supplementary documents. There's an engagement tool, which packages interviews, focus groups, workshops, observations, and simulations to allow others to replicate our human-centered design process of engaging users. And then next slide, there's a more technical assessment tool as well, which is aimed at evaluating the condition of existing buildings to inform decisions about what can be renovated or when new construction is needed. Next slide. The design principles document contains more overarching design guidance and recommendations for maternal and newborn care spaces, space by space. Next slide, and it also highlights key design elements and considerations for how design can improve outcomes and experiences. Next slide. And then finally, the case studies document demonstrates how we applied all these tools, the design process and principles, to specific facilities in Ethiopia and Bangladesh, and then the designs that resulted. So just given that we're short on time, I'll just give you a quick glimpse of what these are, but you're welcome to look at the case studies document more in depth. Next slide. Oh, sorry, keep it going one more. So Munshiganj in Bangladesh is an example of how existing infrastructure can be upgraded. This was an urban hospital that was in the midst of constructing a new building on the site. It's that the building that you see to the right, that's up and down. So the overall building floor plan was fairly logical, but the relationship between the maternity programs was not ideal. They were on different floors, and many of the spaces were really undersized. Next slide. So we worked to provide recommendations for how to consolidate maternity services with as little disruption to walls and building services as possible. Next slide. So beyond the fact that it was reusing an existing building, other climate responsive moves included ensuring operable windows for ventilation, shading patios to limit heat gain in wards, and then locating family waiting, which you see in the yellow here, in a more central area that is directly adjacent to openings to the outside to limit congestion. Next slide. This is just one of the interior views of a proposed ward. Next slide. Addis Zemen was a primary hospital in Ethiopia. Next slide. There was a single building housing the OR unit to the right, all the maternity and newborn programs in the middle, and then a male ward to the left. And it needed significantly more space. I think something like a 4 to 6 fold increase in beds. Next slide. So we proposed to retain labor and delivery in the existing building along with the OR. We designed smaller 4-bedded pods connected by a labor walk to provide greater privacy to patients while still allowing effective caregiving and oversight by staff, and then larger delivery rooms for higher quality care. Next slide. But we did need to build additional buildings to house the postpartum and NICU programs and had to arrange those on a very steep site to make those work. Next slide. For the new buildings, we did have an opportunity to leverage a lot of climate responsive strategies, narrow floor plates, operable windows, optimized for cross ventilation, making sure to orient the buildings to minimize solar exposure, pitched roofs for rainwater harvesting, and modular designs to accommodate expansion over time. Next slide. And one of the things we learned about in the engagements process was just the importance of accommodating traditional coffee ceremonies, which was a more important determinant of facility birth than even access to emergency transport. So we made sure to embed spaces for coffee ceremonies in the kind of site design of the postpartum buildings. Next slide. We also leveraged thick stone masonry walls to absorb heat during the day and radiate out at night for better temperature control in the interior, and laid out a full NICU with the critical support spaces that are needed to enable care, which are often missing. Next slide. Here's just a view of the mother-baby patio from the end of the NICU, looking towards the end of the building. And Pierre, I'll pass it back to you.
Thanks so much, Amy. And time is not our friend today. We are due to go to a panel discussion, but I wanted to just acknowledge some of the important questions that are coming in through the chat. I think Heike Mshana asked an important question about retrofitting existing facilities. And Amy, I think you just answered that question to some extent, in the sense that I'm hearing from you that ideally we would want to create a new blueprint for the future for how buildings should be designed. But the reality is that we do have all of the existing structures. And I think you gave a very nice example of some kind of combined approach where there is some retrofitting or some reorganization of the existing space that can really help with particular issues around flow, but that ultimately, looking to the future, actually in the long run, it is cost effective for us to think about designing buildings that are centered on addressing both the issue of the climate as well as the patient-centeredness that we've heard through. The other topics that maybe we have just a moment that we can hear from our panelists on. The first one, there were a couple of questions in the chat about the importance of patient-centered designs, of including patients and families in the actual designing of these new designs. And maybe I could ask Dr. Shahidullah about the extent to which it's possible and necessary to include patients. And I'm wondering, in the research that's going on across the world that you showed us, to what extent are we making sure that patients are included in these designs? Dr. Shahidullah, if you can come off mute.
Thanks, Pierre.
Okay.
Yeah, that's a very catchy question. Unfortunately, in low and middle income countries, and particularly in Bangladesh, when we make a design or construct one particular health facility, we never ever consider the patient's requirement, their demand, their expectations. And that's the reason when Hema was giving us a kind of an example where she found that the facility has got beds, but there are no patients. Why? Because the patient didn't feel comfortable. I mean, and they didn't think that it is a welcoming environment where I can go and get my service. So this is, I would say, very crucial for the planners, for the policymakers, and even the clinical people like us. When we are going to construct any kind of a service for the mother or newborn, particularly I'm talking about that, to consider the views and the demand and the requirements of the patients. And if that is done so, perhaps we will not see that the beds are remaining empty. I'll stop here.
Thank you so much, Dr. Shadil. And I wanted just very briefly to ask Manara, I know that there was a very deliberate effort to spend a lot of energy and time in your work on maternity spaces to survey mothers and families and healthcare workers, and just describe the process that you took to make sure that that information, that knowledge was incorporated into the designs that you came up for better maternity spaces.
Oh, absolutely. So we actually use the concept of human-centered design, and we were very purposeful in how we asked those questions to really learn from a range of different stakeholders, mothers, their caregivers, members of their families, and even the service providers as well, to really understand what matters most to them when it comes to space. And, you know, some members of the community said, well, actually, cultural practices are important to us. Others said that religious rituals are important to us. And those are the things that made mothers more comfortable and their relatives and their family members. Similarly, from a healthcare worker perspective, really understanding about clinical adjacencies was important to them. They didn't want to really move around between lots of different spaces and then find that, you know, it wasn't optimized in terms of care or timings even. So really taking all of those viewpoints and then incorporating them, the principles into the design. And I think this is the importance, Pierre, that it's not about the individual requests, it's about the principles, and that's what's incorporated into design.
Thanks, Manara. I just want to acknowledge that there are some really great questions coming in the chat. We are going to have another question and answer session after the short film that we're about to show. So please do add your questions and comments to the chat. I'll do my best to summarize, acknowledge them, and put them in front of the panelists. Before we go to the movie, I wanted to just acknowledge Dr. Aminul Hassan made a very important point about the disproportionate impact of climate change on rural and low-income populations, and the importance of designing resilience and self-reliance for these local and far-flung communities. And he pointed specifically to ideas around using renewable energy services like solar and wind to ensure independence from the grid when there are major disruptions. And I wanted to acknowledge that as an idea, and maybe we can come back to that as a specific tactic. So we now have a short film that gives us a look into the Kenyan context of healthcare space. It's every mother's right to receive the care that makes her feel welcome. And I think we've heard from a couple of the panelists about this idea that the space that we create has a major impact on access, because mothers will come to places where they feel welcomed and well taken care of. So let's have a look at this movie that takes into account the birth journey, making sure that it's patient-centered and respectful. If we can show that now, please.
Kenya, a country celebrated for its stunning landscapes and rich cultural heritage, hosts vibrant communities that thrive amidst challenges, where the healthcare journey is defined by struggles as well as resilience. From the bustling streets to remote villages, mothers and families navigate a complex landscape seeking access to quality healthcare, much like countless others around the world.
Mimi nilianza kuhukumiwa nyumbani na ilikuwa saa 3. Nikaignore kidogo ikafika saa 8. Nilikuja na boda, fika kwa gate watchman akafungua tukaingia. Nilipata nurse mmoja na students. Akaniambia tu please enda kwa coach na kuja na gloves. Akaniambia mtoto ni mkubwa, you need energy.
So mimi nitoka nyumbani nikikuja kunifungia hapa. Hakuna privacy, like kama mko watu watatu maybe tuko labor, nyote mko hapo ndani. Hakuna very enough. Shoni kimoja na labda mko wili, unaona unaoje ile mvuya maliza ya kwanza ndio pia wewe uende utumie choo. Pia kwenda hiyo kuoga usiku pia unaoje yule amaze kuoga ndio pia uende uoge. Na labda unasikia uchovu na fondo pumzike, tepi inakuwa changamoto.
It's like a drama scene. That delivery room is very near to the wardrobe. Penye watu wote wa. It's time out traumatizing if somebody's delivery and you're still here to wait for. You see, to get the whole trauma before it reaches your time.
Birth is the moment when life begins, and yet mothers across the world have vastly different experiences of childbirth. Within Kenya's evolving healthcare landscape, strides have been made toward progress. Yet there remain many opportunities to further improve maternal and newborn care to better meet their needs. Recognizing the impact of birth environments to ensure a continuum of care is crucial. Ensuring quality, equity, and dignity during the motherhood journey not only guarantees the mental and physical well-being of mothers, but it also encourages positive healthcare-seeking behavior, such as opting for institutional delivery, staying for the suggested time for postpartum care, and saving the lives of mothers and newborns, all while receiving emotional support from their companions. Too often, mothers find themselves in spaces unsuited to their needs, hindering healing rather than aiding it. As much as healthcare providers struggle in these settings, mothers and their families miss out on essential health checks, with mothers opting for early discharge due to discomfort.
We have 2 delivery coaches. When things go haywire, you need to intervene, come in with the CPR, just make sure you are saving a life. The space around it does not give us room for a team to come in and coordinate a resuscitation that is effective.
Nilikuwa naogopa kwa sababu watu walikuwa wanaambiwa experience huko nje ati ukienda hospitali kuzalia hospitali labda uchelewe kuleba, usikume mtoto wakati kutoka haraka, sasa wanakupiga, wanakugombeza,
unasumwa wanakuchapa.
So I was scared.
You know that was your first pregnancy
in hospital.
Fear of the unknown overwhelms first-time mothers, compounded by the shared experiences of those who became mothers before them. However, if their first birthing experience makes them feel safe, respected, and heard, it can change everything.
Unaona kama mtu kuna mtoto wake nafaa kuwa privacy na mlio mtoto hamshughulikie. Like hizo unaona made mnashare to a windi na kila mtu kuna mtoto wake, inaikuwa ni convenience to the first mothers. Wenye hawajajua take care of the baby, so nataka ule mtu amekuja na yeye akae kwa hiyo kitanda, inakuwa si vizuri.
From pregnancy to delivery and through postpartum care, it is every mother's right to receive the care that makes her feel comfortable. The healthcare spaces used throughout these stages must be designed with a mother's needs in mind, ensuring they receive what they want most, just like Medina, Dora, and Stella.
Thank you. What a powerful illustration of both the issues and also a look into some of the potential solutions. So we wanted to use the last 10 minutes before our closing just to reconnect with our esteemed set of panelists, but also to connect to some of the questions that are coming through. I think what we've experienced from this very impressive set of presentations and certainly from some of the questions that you're asking, that there's a deep need to understand what the issue is, what really matters to mothers, what really matters to healthcare workers, in terms of their experience of the environment that they encounter, that the mothers encounter when they come into these healthcare spaces, and the environment in which healthcare workers are trying to do their job, the profound effect that has on them. And then what I've observed is an inquiry process, a research process that really starts to test some of these ideas and understand through testing and research how easy or difficult it is to implement some of this basic understanding of what mothers and health workers need. And then finally, we also heard about how important it is to have a systematic way to incorporate these ideas, this testing, and the realities of government finances into the most efficient way to create the spaces that give mothers the best chance and health workers the best opportunity to provide the best care. I loved the quote that stuck with me from that Kenyan movie was the nurse saying, "This is like a drama scene." And mothers are experiencing trauma even before your time has come. So they're observing what is happening around them, and it's not conducive to the kind of experience that we should be offering our mothers and health workers at this very important time. So with that framing, I suppose I wanted to maybe ask Bertha to give us a sense of how the WHO can help in bringing these themes of inquiry, research and testing, and then introduction of the best ideas into government. I will get into the funder question in a second, but maybe very briefly, Bertha, you can help us understand how do we move forward with all of this?
Yeah. Thank you very much, Pierre, and thank you to all the panelists and presenters for sharing their thinking, their work, but also opening for us new avenues of working and bringing different streams of work that normally don't belong together. And I'm saying this first because this is a completely new way of thinking through how do we ensure not only universal health coverage, but universal health coverage with quality at the center that responds to this dynamic environment with all the changes, but at the same time responds in a way that keeps people at the center. So linking all these different strings is not very easy, and at times we have to think about what are the entry points in terms of what is it, where do I start my work, where do I start my action? Do I start with additional research? I could see that in the chat there were quite a few questions regarding research. Do I start with changing what I already have, or should I start with the question, what can I do today and what is the best way to guide the system for tomorrow? And for me, given that I come with a very clear hat from a quality of care and patient safety perspective, I think the first entry point would be in not only reorganizing the health system, so everything that goes underneath the availability and accessibility of facilities and referral systems, but thinking about facilities as the point that not only provides care, but brings the community together with a focus on the patient and the user. So perhaps in the discussions, the user-patient focus came towards the end with the idea of a participatory design. This is a way that needs to be institutionalized in our thinking, in our planning. For me, the entry point in the planning is always when you think from the strategy from the top to the bottom, and then ensuring that that participation is part and parcel of our today's discussions, but also today's discussion with this notion of we need to be fit for the future, and we need to be for the future that is currently today in this climate change area. So I think bringing that patient focus and the user community focus up front in thinking through not only designing for better access, but designing for better quality with people in mind is one aspect that I'd like to highlight. Many countries are developing strategies and policies on quality of care and patient safety. This could be an interesting part or entry point for thinking through what does it mean in the patient journey. The second part goes mainly on the area of the climate change and what is the work that we are doing to prepare our health systems so they are resilient, and not only resilient to respond to the challenges, but also resilient in a way that they don't create waste. Some of the presentations that were shared, they may not have touched directly. I think Amy's presentation, she gave a few images and a few on the bullet points in terms of what is our impact in the environment. So looking at those local solutions that allow us to build structures that are fit for purpose, people-centered, but also that are respectful and then do reduce our environmental impact. That may be a challenge, but it's not impossible, and we need to think through. And the third line that I'd like to bring is that none of us knows exactly how this needs to be rolled out. So this is a great opportunity for learning, exchange, and building the solidarity around how do we approach this from different angles, from low and lower income countries that may not have all the resources in place, and those are high income countries that maybe have made strides and have learned a bit faster or more on how do we learn from each other, and also bringing maybe in the high income countries those local solutions that are very efficient and environmental friendly that perhaps have been forgotten over the years in terms of what does it mean to build systems that are resilient and facilities that are resilient and respect the environment based on local traditions and that respect people's needs, but also culture. So I'll stop here and I'll hand it over to you.
Thanks. I think we probably have time for just one more. And so I suppose I'm going to turn to Hema and ask you to take off your implementer's hat, which you gave us a wonderful insights earlier, and perhaps try to help us understand, I think, a really burning question, I think, for this topic generally, which is how on earth are we going to fund these changes? I think we've seen that simple systems changes, readjustments of flow, changes in culture, of course, we can start working on that with what we have. But some of the changes that are being proposed really do require either adaptations of existing structures or new designs. How can we get, as one of the speakers said, a change in the mindset to think about the sort of the long term rather than just the short term budgets? From a funder perspective, how do you have those conversations and help us to get past these hard questions?
Yeah, thanks, Pierre. I mean, I think this is the question, and I think we don't yet have the answer, but I think that's what we're all working towards. I think there are a few aspects. I think one, and we've talked about this a lot, excuse me, is the importance of the patient experience. But I want, and the importance that is to access. But I also want to make sure we don't split this too much from the clinical quality of care. We can have a beautiful building that a patient loves that provides terrible care. I think we've seen that, and that's not what we're going for. But then we can also have terrible buildings where you're trying to provide pretty good care. There are obstructions, but you've got good science people don't go to. So that's also not what we want. So it's really pulling those two together, that it is not just a nice to have, but it's a must have that serves patients and healthcare workers and with efficiency to be able to deliver on patient outcomes. So I think when you pull those together, the cost question also changes. The investment case is a bit different. It's sort of not only the cost of doing it, but also the cost of not doing it, the cost of continuing the status quo, building facilities based on unscientific designs, because hospitals keep getting built. You know, there isn't a lot of money, but it is still being spent. And so there is a lot of wasted money in that system. So it's kind of lining up the evidence, the innovation, then with the right stakeholders. I would argue that most likely there are very few people in this room who need to be convinced. And in this room, though, we're probably not having that many of the finance people in ministries of infrastructure, finance, folks from key funders like the Global Financing Facility, World Bank, These are kind of the folks that all have to be pulled together to this conversation. And there's huge amounts of advances in this area. Maternal newborn health is a place in need of major widening of the fiscal space. And there's a lot of efforts in that. GFF and Bank have been making huge strides in trying to pull this together. WHO right now is also making norms for small and sick newborn care that includes space in HR. And yes, that's going to be difficult, but at least it helps to set the bar so that as you're designing, you have to fix the plane while we're flying it. We have to do the renovations, trying to employ those design principles while also, while we're flying it. And we also have to design for the future. And I think when we align those together to create the right investment case and the governance, like Dr. Abbas shared, is where you can make big impact. Thanks.
Thank you so much, Hema. What a wonderful way to end and bring us together. I want to finish by just thanking again all the speakers, and also to thank you all for, we know we didn't get to all of your chat questions, but I hope we covered a lot of them. What a wonderful opportunity to hear about this important topic. And I'm going to hand off to Anuradha Pichamani to bring us home and say goodbye.
Yeah, good evening, everyone. Thank you, Perry. It's a pleasure to be with you all here today. And we have been discussing a matter that's not just critical to our health, but to the future of our planet. And our health is directly tied to the health of the environment around us. And as we face these challenges posed by climate change, it's essential that we rethink the way we design. We design and operate our healthcare spaces, and we need to integrate the climate resilience into the design of healthcare facilities. So the recent ISQua conference, which we had in Turkey in September 2024, it brought the attention in a vital intersection of climate change, public health, and healthcare systems. So leading experts in the conference shared insights on the various strategies of building climate resilient healthcare facilities, reducing the environmental footprint of healthcare operations, and addressing the growing health risks posed by climate-related challenges. So the conference also underscored the urgency of collaborative action by all the stakeholders involved. And as a ISQua board member, I'm very pleased to inform you all that ISQua has published a green paper as a call to action for the environmental, sustainable, and climate resilient healthcare systems now. So this green paper outlines the practical steps and actionable strategies to help healthcare systems worldwide to build resilience and to reduce their environmental impacts. And it's a testament to ISQua's commitment to mobilizing its vast network to tackle this critical challenge. And as a clinician, I see on first hand the profound influence that design and layout have on the quality of care, on the patient experience, and even on the operational efficiency. And especially as we were all discussing on a low middle income country like India, where I come from. And patient-centered design, it goes beyond aesthetics. It creates an environment where that prioritizes patients' comfort, it prioritizes patients' safety and autonomy. And hence, by considering these emotional, psychological needs of patients, we would be able to design spaces that not only promotes healing, but also reduces the anxiety, the stress, which all helps you to improve the outcomes of the patient. And again, we were talking about maternal health. So I'm a practicing OBGYN consultant, and this idea of a thoughtful design is especially important in spaces which includes the labor room, the delivery rooms, the NICU, the kangaroo mother care, postnatal wards, because the experience of childbirth matters to each and every mother. The environment can significantly impact the experience of both the mother and the healthcare team. Labor and delivery room that is designed with care, it helps you to reduce the stress, it helps you to improve the safety, and gives a trust to the patient and promotes relaxation, all of which are important for a positive birth experience, which WHO has been giving us about. Again, proximity to the equipments, ergonomic layouts, and all that are very crucial. And as healthcare professionals, we have a responsibility to create an environment that not only supports the physical and emotional healing of our patients, but also protects the planet for the future generations. So the spaces we design, the choices we make in healthcare settings will all have a lasting impact, not only on the patients we care for today, but on the generations to come. And I would like to express my appreciation to everyone involved in organizing today's event, for all those working tirelessly to build a more sustainable and resilient healthcare future. Together, we would make a significant difference in both healthcare and environment. Thank you. Over to Perry.
Thank you so much. And thank you to all of you for staying with us and hearing out these wonderful speakers and observations. And there will be a recording and slides sent to you soon. So thank you and goodbye.